Hi, so we are still in 303, Lesson 1, and we're going to go through some of the treatment planning and diagnostic forms that you can use for your patients. So this is a kind of an exciting part of orthodontics, when you start gathering information of, all the problem lists. And, we talked about it previously that when you see a patient, you want to come up with a problem list, and then once you have a comprehensive problem list, you're going to come up with a solution list that's going to match your problem list. And that's really how you diagnose patients successfully. And it helps to use a form, and you can look for a form or you can create your own. I'm going to show you a couple that I use, and originally we developed these forms to help students get organized, as well as orthodontics residents to get organized with their diagnostic efforts. So there's two documents here that I like to go through. One is Google Doc that you're welcome to use for free. It's just on our website, so I'm going to show you that. And the other one is a PDF document that I personally use as well, just to organize my diagnostic efforts. And I suggest that you use something similar to systematically diagnose your orthodontic cases. Okay, so I'm gonna start by looking at the PDF form first. So I'm gonna show you how to get there. Okay, so the way you get to these forms is first, when you arrive on our website, you're going to go to the Mini-Residency. So you go to Courses, Webinar Support, and click on Mini-Residency, or there are several different shortcuts on our website, but you need to get to basically the Mini-Residency page. This is the title page for the Mini-Residency courses, and you can see that this is where all the courses of the Mini-Residency are located. And what you have to do is scroll down until you see this form, the NOA Diagnostic form, and all you have to do is just click here, and then it opens up and you can view it. Now, the other thing that you can do too, you can also download it. So if you click on a download link, it's going to download it, and you can print it and write on it, change it, whichever way you like. Okay, so I'm going to go through this diagnostic form, and there are several different ones that are like it, but this kind of helps to organize your thoughts. And there are also some diagnostic forms in your book, and there's millions of them on our website too. I mean, on the internet, so you can Google them. There's really you can just use any one that that you like. But there's several key aspects that I think important with a good diagnostic form. So let's go through this kind of systematically, okay? So the first point is you need to write down what's the patient's concern. So this is where the patient's chief complaint is going to go. Like, why are they coming in to seek treatment? Why are they coming to your office? What would they like to accomplish? So it's very important to write this down with the patient's words, okay? So don't try to rephrase it. Just write down what they're saying, or why they're coming in, or what's bothering them. Okay, then you're going to go to number 2, which is profile. Okay, so profile is exactly what it says it is. It's just you're looking at the patient's profile. So is this patient straight? Is it convex or concave? Obviously, convex is going to be class 2. Concave is going to be class 3. So this is where you're going to put that information. Now, frontal, so face frontal just means when you're looking at a patient in a relaxed position, just from the front, and then you try to decide, are there any asymmetry that's obvious to you? So this is just looking at it. You're not looking at any cephs or anything like that at all. You're just looking at pictures. Okay, so when you look at the face frontal, you just want to look at the picture when a patient is not smiling. Okay, and then just see if you see any asymmetry. You could say that like the chin is to the left, or maybe the eyes are uneven, or anything that you notice on a frontal face. Okay, so that would be just at a quick glance. Okay, now after that we are going to go to the skeletal analysis, and then after that we're going to cover the dental issues. So we're going to do first the profile and the facial aesthetics, then we go to the skeletal, then we're going to go to the dental classifications, and then we're going to go to the periodontal and then the airway. So this is how we kind of organized our diagnostic form. Okay, so we've gotten the beginning done, patient's concern, profile, and facial frontal aesthetics, so how that looks. And after that you're going to go to skeletal problem list, and you're going to need to do the the cephalometric tracings for this. So basically I suggest that you come back to these diagnostic forms after you've done all your records analysis. You're going to do your ceph, you're going to do your model analysis, your arch analysis, and then the crowding, the class 2. And I usually fill out this form while I'm looking at the records. Okay, so but I trace the ceph first. So that's the first thing I do. I trace the ceph first, then I come to this form. Okay, so before you come to this form, I would definitely trace the ceph, and I would put in the patient's chief complaint, and the rest of the information you can get off of the records. Okay, so by the time you get to the skeletal problem list, you're going to have the ceph traced, and then you should have the patient's records open. Okay, so first we're going to go to skeletal frontal problems. Okay, so if you saw some frontal problem here, for example, the patient's chin is to the side, maybe then you need to take a frontal ceph. So there's a lateral ceph and there's a frontal ceph. So if you see any frontal problems like asymmetry, then you really need to take a frontal ceph, and you're going to see if there's any asymmetrical problems on the frontal ceph. Okay, so this is the skeletal frontal problem. Most of the time you're not going to have much here because most of the patients are fairly symmetrical, but there are some patients who have a cant or asymmetry. So this is where you would put, like for example, patient's chin's deviated to the right, or upper maxillary cant. So you would get this information, for example, from a frontal ceph. And we're going to cover the frontal ceph in later seminars, so we'll come back to that, okay? You're going to do, also you're going to do the same thing here, frontal, facial, skeletal, asymmetry, okay? So this is where you're going to highlight here what problems you see, and here you're going to see, you're going to look at your frontal ceph, and you can put in your values, like how many degrees the maxilla is canted, or how far the chin is off, okay? So you put all your information here, first what you observe, and then you put in like a value, like, the upper maxilla is canted down 10 degrees on the right, things like that. That it's not going to be very common. So this is going to be not going to be common for all your orthodontic cases, okay? But this one will be common to every orthodontic case, which is number 6, skeletal A and B. So this tells you if the patient is skeletal 1, 2, or 3. So you would put in skeletal 1, 2, or 3, and I usually put in the A and B value. So I may say A and B of 5, skeletal class 2. And then after that, it's going to be maxillary position based on a cranial base. So that's SNA. And you would say here retrognathic, normal, or prognatic. Okay, so usually they can have about 3 values. Mandible position could be prognatic, retrognathic, or normal. Mandible size, that's condyliantognathion, that tells you the length of the mandible. And I would just say here short, normal, long. And you could put a value in there like how many millimeters. This will all come off of your cephalometric tracing, okay? And we're going to practice this with an example case, but first I need to explain the form to you, okay? So then we're going to have the skeletal vertical, so that's going to be your FMA, and I would put in like the value, like for example, FMA of 16, that would be deep bite. So set skeletal deep, skeletal open, skeletal average. So, FMA of, let's say 32, skeletal open. FMA 16, skeletal deep. Okay, so this is going to be deep, normal, open. Asymmetrical mandible, so obviously it is what it is. So for example, if the chin is to the right, sometimes because the mandible is asymmetrical and it's off to one side, okay? And then we're going to come to the TMJ from a panrex. Do you see any abnormalities on at the TMJ area? On a panrex, do you see anything on the TMJ x-rays? We take TMJ x-rays as well. So here you're going to mark that maybe contour resorption, or when a patient opens, the condyle doesn't slide down the eminence evenly, so it's off. So that's what's going to come here. And then you're going to have the intraoral exam, which this information comes from your intraoral exam, the TMJ clicking, popping, or locking. And you could put, like, if the patient has some clicking, is it anteriorly displaced disc with reduction, without reduction? So all that information would come here. And then Tmj Contour Resorption. Okay, so obviously, if you see contour resorption, then you're going to have a bigger problem than just orthodontics. But you really need to screen all patients for contour resorption, especially females between 12 to 20 or even 12 to 30, especially with the anterior open bite. So TMJ contour resorption, you would just say here normal, none, little bit, severe. And if you do see contour resorption, you need to refer that patient to a surgeon. And we're going to cover that in our contour resorption seminars, okay? And then we're going to come to cross bites, okay? Do you see a cross bite? You could be anterior crossbite, it could be posterior crossbite, or it could be both. So you would just say right here, anterior, posterior, both, or none. And then here, crossbite in class 1 occlusion. So this is a little bit different. So when you see a class 2 patient, like we talked about it a little bit before, sometimes you cannot see the crossbite. When you put that patient in class 1 occlusion, then you can see the crossbite right away, okay? So it's those patients and you're going to get this from your model measurements. And we're going to show you when we do the model analysis how you can tell if there's a crossbite in class 1. If you do your model measurements and the lower arch is, let's say, 50 and the upper one is 48, there is crossbite, okay? So you're going to measure at the buccal groove to buccal groove on the lower sixes. You're going to measure the mesiobuccal cusp to mesiobuccal cusp across on the upper arch. And if the upper is not larger than the lower, then you have a crossbite in class 1. So if the lower buccal groove to buccal groove on the lower sixes, let's say, for example, 50 millimeters, and the upper arch, upper sixes, mesiobuccal cusp to mesiobuccal cusp straight across is, let's say, that's 46, then you have 4 millimeter crossbite in class 1. Okay, we're going to practice that when we practice the model analysis. Then we're going to come to the dental analysis, and here we have number 18 is the dental class, okay? So this we covered in a previous seminar too, and we're going to have also a lot of practice on this. You need to say like class 1 or class 2, and then remember this part is the molar, the upper right molar. This part is the upper right canine. This is the left canine. This is the left molar. So you're going to say class 2, 2, 2, 2, 2. That just means they have a class 2 everywhere. If they have class 2 here, but they have a class 3 at the left canine, then it will be a negative sign. So you could say class 2, 2, 2. So that just means class 2 on the right side. And then you would say -3, that would tell you that there's a class 3 canine on the left side because there's a negative sign because you said class 2 here, okay? So, or you could say class 3 if a case is class 3, and then you would put how many millimeters class 3. If it's class 2, then you would say how many millimeters each of those sections is class 2. Is the is the molar on the right side how many millimeter class 2? Here you would put how many millimeters of class 2 the molar is. Here you would put how many millimeters of class 2 the canine is on the right side. The double hash means the double dash means the midline, and this is the left side. So on the left side at the canine, how many millimeters of class 2 there, and the left side at the molars, how many millimeters of class 2 there. So this is where your dental class comes in, okay? If the patient is class 1, then you don't put anything here because it's class 1 everywhere. Or you could put, okay, so here's crowding. So for crowding, you're going to say how much crowding on the upper arch and how much crowding on the lower arch. So I usually say maxillary crowding 2 millimeters, mandibular spacing 2 millimeters. Or maxillary crowding 5 millimeters, mandibular crowding 9. So this is where you put the amount of crowding. And you really need to practice the crowding. When you start out, usually you underestimate the crowding, and that's not good. So we need to be really accurate with the crowding calculations. And that too, we're going to have a lot of practice with that too. So you need to get really good at calculating the amount of crowding, okay? Then we're going to talk about dental bite. Dental bite can be deep, normal, or open, okay? So that's just the dental. You're just looking at the patient, how much overlap the front teeth has. If it's overlapping completely, that's a deep bite 100%. overlapping halfway. The upper teeth overlap the lower teeth halfway. That's 50% deep bite. This is normal. These are the anterior, the front incisors, and this is open. So it's just open, normal, or deep. And then you could put severe, moderate, or mild, or 100%, 50%. So you can kind of indicate the dental bite. And then we're going to, like I said, we're going to practice this with cases, so then it's all going to make sense, okay? And then 21, we're going to look at the maxillary transfers, upper 6 to 6. That's when you measure on a patient's arch from the upper molar to upper molar. And I'm going to grab a Typodont here so I can show you. So what you do here is you measure from the lingual of the upper sixes to the lingual of the upper six. Okay, so you just measure straight across. That's the transfers, upper 6 to upper 6. Remember, coming from McNamara. So again, you measure from the lingual of the upper 6 to lingual of the upper 6 groove, and that's going to tell you the quote-unquote ideal should be about 35, 36 to 38. It's just kind of like a good guide. If you see 27, that's very, very small. If you see 30, that's quite constricted too. 33, 34 is closer to normal, okay? So then we're going to come to the crossbite calculation, and that's just like I told you. We're going to measure. You're going to measure from the lower 6 buccal groove to buccal groove straight across, and you're going to measure the mesiobuccal cusp to mesiobuccal cusp on the upper, and that's going to give you the calculations for the crossbite. Okay, the upper needs to be bigger than the lower, and it should actually be about the same in class 1 occlusion, because when a patient occludes in class 1, the mesiobuccal cusp occludes with the buccal groove. Okay, so if the mandibular arch is wider than the upper, there's a crossbite. Or you can have actually anterior crossbite too, but that's different. That's under the different category. Okay. Here you're just trying to get the amount of crossbite, okay? So all you do is you measure the maxillary arch, how wide it is, then you measure the mandibular arch and you subtract it, okay? If you get a negative number, you get a crossbite. Because if you get a negative number, that means the mandibular arch is bigger than the maxillary, so you have a crossbite. Scissors bite, okay? So scissors bite is when the let me show you an example. Scissors bite is when the upper arch is way buccal to the lower arch. It looks like this. So basically, the lingual cusp of the upper teeth is buccal to the buccal surface of the lower teeth. Okay, that's scissors bite. Okay, so you need to see. So this would be, so crossbite would be when the upper arch is smaller than the lower. Scissors bite would be when the upper arch is bigger. So it would be like that, for example. This is quite severe. So that's scissors bite. So if you see that, you need to mark that. That comes right here. Bolton analysis. Okay, so 24 would be the Bolton analysis. Interior ideal is 77.2. Bolton analysis full arch is 93.1. So whenever you do your Bolton analysis, you're going to have a value there, and you just put it there, and you put the values here, and it's going to tell you if your case has Bolton problems, like for example if the laterals are too small. Then you're going to go here, which is the proclination of upper anterior teeth, and also proclination of the lower anterior teeth. Are they normal, proclined, or retroclined? Okay, so what you're going to put here is actually proclined, normal, or retroclined. Or you're going to put, you can put the value here too from your cephalometric tracings, or you could just say proclined, normal, retroclined. I'll just say proclined, normal, retroclined, whichever it is, okay, for both of those arches, okay? And then you're going to have asymmetrical dental. So for example, if you have a molar more mesial on one side and the other side, then you're gonna put in here, you put that under the asymmetry for the dental asymmetry, okay? So if you see any asymmetry with the teeth, that's where it would go, okay? So now we're going to talk about asymmetry, dental asymmetry. Upper ones to the face, okay? So that's upper midline. It will be 0 if it's correct, or it could be left to right. So for example, if upper one is right to the face, then you would put in how many millimeters it is to the right of the face. If the upper centrals are left to the face, how many millimeters it is left to the face. It's very common to be off if the canines are impacted, okay? Also, is there a functional shift? Functional shift is when a patient bites and the jaw slides open on the slide and the jaw deviates. So that's a functional shift. Also, taper teeth, small teeth, or small laterals. So you're going to mark it here if you see any taper teeth or small laterals. If you see that, you're probably going to have a Bolton analysis problem too. Then you're going to go to missing teeth. You need to make sure there's no missing teeth. And you're going to go to tip teeth. Like, for example, if you have an impacted one that's really tipped, that's a good one to mark which one is it or how bad it is. For example, lower sevenths could be really tipped and impacted. Dental conditions of all of the teeth, do they have a lot of crowns? Do they have a lot of root canals and things like that? Sinus, okay? So the sinus could be normal, low, or high. The lower the sinus, the worse it is for moving teeth, as well as extraction cases. It could be very difficult with a low sinus. Impacted teeth, if a tooth should have erupted but they haven't, that's impacted. If a tooth is not coming in because there's no room, that could be ectopic, but it's not time for it to erupt yet, okay? So that's an ectopic tooth. So you need to see, does the case have impacted teeth? Does the case have ectopic teeth, okay? The difference is if the teeth should have coming in but it hasn't, then it's impacted. If the tooth should have not coming in yet, but it's not coming in because there's no room, then it's ectopic. Root resorption, visible at start. Do you see any root resorption on the case? Gingival display, high, normal, low. Okay, so how much gingival display do you see when a patient smiles? And then root canal treated teeth, you need to put that down too. If you see any ankylosed teeth that you would put here, you have to tap on the teeth, as well as usually if you see a primary ankylosed tooth, it looks really low and the adult teeth kind of tipped over it. That's usually a sign of an ankylosed tooth, but it could be an adult ankylosed tooth as well. Then you're going to come to the periodontal issues, okay? Periodontal health. Is it healthy? Gingivitis, perio issues. Hopefully you have no perio issues, because you shouldn't do orthodontic treatment for those patients. And then here you're going to come under pockets. Does the patient has any pockets? Should be normal. Does the patient has any recessions, mild, moderate, generalized, localized, and you would put all that information here. Periodontal bone loss. Patients could be healthy now, but maybe they had bone loss in the past, so you have to put that here. History of periodontal issues and disease, so that's where you would put here. Maybe the patient has periodontal treatment before. And then here you would put the oral hygiene. Is it good, fair, great, poor? And if it's poor, I would not start orthodontic treatment for them. If it's guarded, I would probably do a couple cleanings and see how things go. 50.50 would be all restorative dentistry on patient's true implant has been completed. It should be completed when you start orthodontic treatment, so make sure that's done. And then wisdom teeth. Are the wisdom teeth need to come out now? Do they need to come out later? What's going on with the wisdom teeth? This is where you would mark that, okay? Maybe evaluate wisdom teeth late after treatment. If you're treating a 12-year-old, maybe it's not time yet. Maybe if you're treating a 20-year-old, the wisdom teeth needs to come out, so that's where you would put it. And then we're going to come to the airway diagnosis, okay? So here's the airway. Any airway issues the patient may have. So this is where you would put it. Does the patient snore? Okay, if the patient snores, they have some, risk factors for sleep apnea. Maybe you should I recommend the patient get a sleep test with their medical doctor, or one of the take-home sleep tests, okay? Are the tonsils big? A lot of kids with large tonsils have airway issues, and they snore and they have sleep apnea. Does the patient has family history of sleep apnea, or do they have sleep apnea that they were diagnosed with? So this is where you put all your airway-related notes, okay? So this form is going to, help you get organized and just help you get put all your notes in here, and I suggest that you use this diagnostic form as much as you can with all of your cases, or something similar. You can redesign it. You can get one from the internet. You can buy one, make one, or so anything you do, but it should organize your thoughts for the case, okay? So again, and you can get to this form by going to the Mini-Residency page, and then you can actually just scroll down, and there's a link here. All you have to do is just click this diagnostic form, and then it will open up in a PDF, okay? So that's one of our diagnostic forms. There's also one that you can just fill out online. You can be anywhere on our website. For example, you could be on a home page even. If you scroll down to the footnotes, here's the diagnostic form, okay? So if you click on the diagnostic form, it's going to pop up with this online diagnostic form, okay? And you have to fill out all of the required fields, okay? So you're going to, put in your email address, and then you're just going to hit next, and then you're going to put in the date. Doesn't matter what the date is, so just put that in. Then you put in your case number. Don't put the patient's name. This is not a HIPAA compliant form. This is just for learning purposes. And then you just put in a case number. You put in the patient's age, and then you're going to put in the patient's main concern. Okay, so this is where your patient's concern will go. Okay, so then patient's attitude towards treatment, you would mark that. Facial type, you just simply pick these drop down menus. You have dolicho, mesio, brachy, so those are your facial types. Okay, facial symmetry, symmetrical, chin to the left, and you just simply pick whatever categories your patient has. Okay, and then you come to profile. Is it convex, straight, concave? So that's going to be your profile. Now, we haven't learned about this. There's a lot of orthodontic residents and orthodontists that use this form too, that already has gone through this. We're going to learn this in a Mini-Residency, so don't worry about it yet. But it's a maxillary, central, incisor, soft tissue, glabella, vertical, and that's basically determines where the central incisor should be. Okay, so what you do is you look at this line. Okay, so this is glabella, and you have a line for the to the forehead. Okay, and there is a point about halfway, the FFA point, and if you draw a vertical line down, then your central incisor should be it's a glabella vertical. Okay, so you just simply draw a line from the glabella vertically down, and your central incisor, the facial surface, is it behind, is it on, or is it is it on a glabella vertical? Okay, so it just helps where your central incisor should be. Okay, it just really, whenever you have a patient, for example, where you're trying to decide if you need to retract the incisors or leave it in place, it helps decide where the central incisor should go. Okay, so you're going to use this in maybe some extraction cases where you're trying to decide if the central incisors needs retracted, need to be left in place, or need to be brought forward. Or, for example, maybe surgical cases too. Is the maxilla needs to advance because is the maxilla retrognatic? You can actually see it from here, like the central incisors should be about on a glabella vertical. Okay, so here's some of the responses. If you are not familiar with this, don't worry about it yet. Just move on, and then you can come back to this. Okay, once we cover this in our seminars. And then upper one, central, midline to the patient's face. Is it normal to the left or right? So that tells you if the upper midline is correct. Functional shift, that's when the patient open and closes, and it tells you if the patient has a functional shift forward or side to side. So if a patient has none, you just fill in none. Gingival display at smile, how much gum tissue do you see? Maybe you see just 2 millimeters, something like that. So that's what you would put in. Lip competence at rest, are the lips together? So you would put in lips are closed at rest, and you get that information from the pictures. Okay. Now, the next one's going to be the dental class. This is what I told you before, that it's going to be class 1, class 2, or class 3, okay? So maybe your patient is class 2, and 2, 2, /3, and 3. So this means the patient is class 2, 2 millimeters on the right molar, 2 millimeters at the right canine, 3 millimeters at the left canine, and 3 millimeters at the left molar. Then, in a mixed dentitional case, how much crowding do you see? How much space, how much crowding do you see in on a maxilla and a mandible? So that would come here. So if in a maxilla you see 4 millimeter crowding, it would come 4 there, and a mandible, let's say you see 7, it would come here. So you could say like 4 millimeter maxilla and and 6 millimeter mandible. Okay, so Oh, sorry. Actually, this is just talking about the maxilla. So this would be just 4 millimeters for the maxilla, because we have an information here how much for the mandible. So let's say 6 millimeters or 5 millimeters for the mandible. Oh, and by the way, coming back here, this illustration just shows you that in a mixed dentition, a molar should be flush terminal. So don't confuse this with a permanent dentition, okay? So if a patient has mixed dentition, this actually looks like a class 2, but actually this is a class 1 mixed dentition. So if a patient is mixed dentition, and this is what you see, this is not class 2, this is actually class 1, okay? So anyway, so the crowding in the maxilla comes here, 4 millimeters, crowding in the mandible comes here, 5 millimeters, okay? Dental bite, you can have average, deep, or open, okay? So that's where you would put here. Overjet, how much overjet you see. Let's say you see 4 millimeters. Open bite, you see anterior open bite, posterior, lateral, progressive open bite, so maybe the patient doesn't have any open bite. Pre-treatment, lower canine width, so that's where if you measure the lower inner canine width, that's where you would put in how many millimeters you see. Expanding the lower canine width actually is very unstable, so we usually try not to expand the lower canine width. Crossbite visible, let's say you have an anterior crossbite, maybe you have some posterior crossbite too. And here's a picture that shows you how we measure crossbite. Okay, so this online form actually helps you also decide how you measure crossbites. Okay, so here you're going to have how much crossbite do you see. You measure the upper arch, the upper width, and then you measure the lower width, and you subtract the lower from the upper. Okay, so if you get 0, that means there's no crossbite. If you get -4, that means there's a 4 millimeter crossbite, because the lower arch is wider than the upper. Upper 6 to 6 transfers, that's the McNamara number that I told you, 36 to 38. You measure right at the lingual groove to lingual groove. Let's say you measure 28. That's very small, okay? Curve or speed, so if you connect central incisors to the lower 6, how deep the arch is from this line at the premolar, okay? So you're going to say average, deep, flat. A lot of people have a deep curve or speed and a deep bite. Upper anterior position, so here you're going to say, is it normal, proclined, retroclined? So that's the upper ones. You measure it with the upper one to SN, and let's say upper teeth are proclined. Lower anterior position, these are normal, proclined, or retroclined. Okay, so that's going to be the information here. Okay, dental anchorage. That just means, for example, if a patient has like a dolichofacial tendency, like they have a long face, that means their teeth move very easily, so that would be poor anchorage, okay? So lower poor anchorage and both the upper and lower will have poor anchorage if the patient has more of a dolicho or longer facial type, you know, kind of like the adenoid face. Those patients' teeth move very easily. So the anchorage is poor if the teeth move easily. Anchorage is high if, for example, in deep bite, patients have like a really deep bite and a strong jaw. That's a high anchorage, okay? Interincisal angle, that's these measurements. Let's say it's average 120 to 140. This information comes from your Ceph measurements. Shape of the upper anterior, well-formed, tapered, peg laterals. Let's say they have tapered teeth, okay? So then we go to the next one. Skeletal maxillary position, it comes off of your SNA, well positioned. Skeletal mandibular position, it comes from the SMB, let's just say retrognatic. Length of the mandible, is it normal, short, or long? So let's say it's normal. Skeletal A and B from the Ceph, so it could be, for example, A and B are 5, so it's class 2. Skeletal vertical, which would be an FMA. So, for example, if a deep bite, let's see if the FMA is 16, it will be a deep bite. TMJ health, let's see they have some clicking. Here are all the other options. Contour resorption from the X-ray. Hopefully there is none, but you need to look at the Ceph. You need to look at the Ceph and a pan and a TMJ X-rays. Growth, okay, so that's where you're gonna go stage the case with the cervical vertebral maturation. If we haven't covered this, then we're gonna cover this, and you'll know how to stage this. But you can stage the cervical vertebral maturation from your cephalometric X-ray between 1, 2, 3, 4, 5, and stage 6. Okay, so let's say your patient is between it's at peak growth. So let's say it would be at CVM 3 and 4. So then we go to the next. And then condition of the teeth, let's just say normal. Maybe they have an implant, maybe they have some crowns and bridges. So that's where you would kind of put that information. Missing teeth, let's say maybe they have all the 8s are missing. Okay, so you could put you know, 1, 16, 17, 32, or all 8s, you know. So you could put in there periodontal health. Let's say they have normal gingival recession. Let's see, localized. They have some recessions. Last, all clear, no decay, periodontal prophy. Current, they had a cleaning within 6 months. Sinus level from pan, let's say that's normal. There are some options, low or normal. You don't want it low, you want it normal at least. Airway evaluation, let's say they have large tonsils, maybe they snore at night. So there's some different options here for that. And then also you have some orofacial problems where they have, like, for example, this kind of resting tongue posture when the tongue is always low and maybe the lips are open, or they can have increased perioral muscle activity during swallows. So this is not a normal swallow. Maybe they have that too. A lot of class 2 patients have that. They could have an anterior tongue thrust like this, or they can have a lateral tongue thrust like that. Okay, maybe they are mouth breathers. Maybe they even have speech issues. So that's where that information would go. And then other notes, TMJ issues, for example, maybe they have clicking. I would just say within normal limits, WNL, so no issues there. And then here you would put your summary of your problem list. You could list all the problems that you find, and then you have a summary of the solution list. Okay, so here you could summarize like everything you find that's a problem with your case, and then here you would put everything that you find that might be the solution for that case as well. Okay, so and then you would hit submit, and then this is going to get sent to your email, or you can print it or save it or whatever you'd like to do. But this should help organize your case. And like I said, don't forget to put in the summary of the problem list here, and don't forget to put in a summary of the solution list here. Okay, or you can leave it blank and then fill it in later by hand, and you just simply click send, and it's going to email you this form. Okay, so this form is, like I said, you can find it in the footnote section of our website, and that's how you get to it. Okay, and then like I said, once you hit submit, it gets emailed to you, and then you have a copy of it. Okay, so good. So those are some of our diagnostic and treatment planning lessons to start with. And don't worry if some of this was over your head or some of this new information. We're going to come back to this many times, and we're going to practice with cases, and you're going to get really good at using these forms and diagnosing and treatment planning, and just make sure that you practice as much as you can and start looking at these forms, or find one like it, or just make one on your own. Okay, but at least for now you get some that you can use from the get-go. Okay, well, good. Well, good luck to you, and make sure practice, and will be really exciting when you start looking at cases and start practicing with these forms and diagnostic tools. Okay, thank you, and have a good day. Bye.